And as you're joining us today, if you could, I'm going to put up a slide to remind you what we need you to enter in the chat so we can count you for attendance. Some people have already beat me to it and they're starting to add it, so I appreciate that. So we need your first and last name, your organization, your email, and if you want to share your job title, that helps us connect with who's working with what programs. So today we have our impact and project scope team here to help us all get through the session. I'm Sue Workman, that's going to be working as the facilitator. We have Melina Danko, who's helping us with all the behind the scenes and technical aspects. Our breakout room facilitators today, we lost 2 of our normal ones just because they're our presenters today, but we gained some others, so we're happy for that. We have Brittany, Leslie, Abby, Susan, Ashley, and Cassie. If you can raise your hand or give a thumbs up or wave to the group so they know who to look forward to meeting with. So we talk a little bit about our ECHO community, and as we all have learned and I think enjoyed, that it's an interprofessional type of group, and we like to meet virtually as an extension of community health outcomes and resources. Our hub members help us put the sessions together, and you all as the spokes join us and help share resources and help answer our questions that we bring to the group. So a community of people who share a common interest, and our common interest centers around neonatal abstinence syndrome and substance exposure. So our session today, we're on session 5. It's going very quickly, but I think it's been pretty enjoyable. And we're talking about monitoring child development and linking of services today in our session. And we have a couple of wonderful presenters that have helped us in other capacities along the way. So we have Judy Romano and Amy Burt. And Dr. Romano is known nationwide for her contributions to the profession of pediatrics. She is a national speaker on early childhood issues, including early brain development, adverse childhood events, early learning, and advocacy. She is the founder of the Wheeling Hospital Center for Pediatrics, where she has developed programs for substance-exposed infants, pediatric rehabilitation services, and autism diagnostic services, while expanding primary pediatrics care and inpatient care. She currently directs the Wheeling Hospital Perinatal Transition Program, a DFMB site that serves on the Substance Use in Pregnancy Committee for the West Virginia Perinatal Partnership. We also have today Amy Burt, and she's an associate professor at WVU in the Division of Occupational Therapy. She earned her master's in occupational therapy from the University of Pittsburgh and her doctorate in educational psychology from WVU. She's worked as a pediatric occupational therapist in outpatient clinics, early intervention, and the school system. At WVU, Dr. Burt provides clinical service in the Faculty Center for Children with Complex Developmental Disabilities, specializing in autism, sensory processing, and unique visual deficits. She also collaborates with the Adapted Physical Education Program at the Friday program and with the Music Therapy and Dreamcatchers Musical Theater Program. She teaches pediatric content for the Division of OT as well as clinical anatomy. She also is highly involved with interprofessional education in the Health Sciences Center, developing programs and educational sessions for students, faculty, and the community. So again, we welcome them today. And if we don't have any other things we need to cover, or Melina, you don't need anything, I'll turn it over to Dr. Romano.
Hi, everyone. It's wonderful to be with you this afternoon. I see we have 65 people already joining us, which is really exciting. And what's exciting for me is talking about child development. That's probably one of my favorite topics after early brain development, which is really about the same thing. So we're really glad, and Amy and I have put together something today, and we hope most of all that we're going to hear from you, because that's what makes all of these sessions so very special, is that we join together and learn from each other. We don't have anything to disclose. So our learning objectives, what are we going to do this afternoon? We're going to focus on the importance of monitoring child development. And in order to do that, I'm going to challenge you all to think developmentally. We're going to be looking at some terminology. Specifically, we're going to be looking at what we mean by certain terms that are thrown around a lot in early childhood, and especially when we talk about development. Specifically, what is the definition? What do we mean by surveillance? What do we mean by screening? And when does screening turn into an evaluation? So we're going to look at those definitions and how those activities actually differ. We're also going to examine who might participate in these activities. And I think maybe this is the most important thing of all, how we can work together as early childhood professionals to have that whole idea of identification of issues and getting them addressed quite early. And obviously the reason we want to do that is we want optimal development for our children. Now today we are going to be focusing somewhat on infants and young children that have been exposed to an intrauterine drug or have developed neonatal abstinence syndrome. And again, as with all our other sessions with SCOPE, we want to hear from you as we talk about our case presentation. So, promoting healthy development. We all sort of think we know what we mean when we talk about healthy development, but how do we make this happen? And who makes it happen? Whose responsibility is it to make it happen? How do we monitor it? How do we measure it? We all work with young children, we all work with infants, and we all know how very, very immature and vulnerable the human infant is at birth. We also know that all experiences impact that developing brain and lay down the foundation for this individual that's going to last for the rest of his or her life. Especially in terms of health, we know that these experiences impact all the way through to adulthood. So, accepting and knowing that experiences in early childhood have this potential to build either a weak or a strong foundation, those of us working in early childhood, have an appreciation for all of the myriad influences there are. We know there's genetic influences, nutritional influences, environmental influences, social, and all of these affect the unfolding of that developmental process. So childhood development is not just about the child. It's not about his or her abilities, but it encompasses the whole family. It encompasses the community. and the cultural context in which this development is occurring. So how is healthy development identified? Or more importantly, how is the lack of healthy development identified? And as we've already said, we're going to figure out whose job it is. And where do we start? Developmental surveillance, the definition says it's the process of recognized children who may be at risk for developmental delay. Well, I would expand that definition, and I think it really applies to all infants and all young children, because all infants, all young children, theoretically could be at risk for a delay. The other thing I think we should talk about with surveillance is that everyone has a role to play. Parents definitely have a role to play, early childhood caregivers, healthcare providers, other family members such as grandparents. All these folks that surround an infant can be looking for the expected emergence of the developmental milestones. And more importantly, they all can be alert to what the so-called red flags or problems in development might be. But as you can imagine, if we're going to depend on everyone to do this, then those adults that are surrounding the child must be aware of what normal development is. And then they can point out when it's not happening. So Amy is going to talk a little more later about particular developmental milestones and red flags and how these can be used in an ongoing process of developmental surveillance. Screening then involves the use of an evidence-based tool, and it's used to identify and to refine recognized risk. And as I said before, that means all children, not just children that we think have been, quote, diagnosed, close quote, as having an increased risk. Developmental screening is very useful for all children. Most of us are probably familiar with the Ages and Stages tool. It is definitely a more formal activity than is surveillance. But we also have to keep in mind that it is not a diagnostic tool. Developmental screenings are most effective when they are done on an ongoing basis and when they engage the parent or the primary caregiver. But not just the parent. Engagement of early educators, of childcare providers, can be extremely helpful in doing developmental screenings. And in fact, I'm going to show you a little video later that I made with the AAP on this topic. So pediatricians, see newborns and young children very, very frequently in those first 2 years of life. And, it used to be that pediatricians thought, we don't need to use a screen. We know what we're doing. But studies have found when pediatricians use, again, a standardized evidence-based tool, their efficiency at finding children with developmental issues goes way, way up. So the AAP for a number of years now has been recommending that a general developmental screen be done at the 9-month visit, the 18-month visit, and the 30-month visit. And those are the well child visits. The AAP also recommends those are general developmental screens, but they also recommend specific screen be done for autism spectrum disorder twice, at the 18-month visit and then again at the 24-month visit. It is a foregone conclusion that doing these developmental screenings really, really enhances early identification of developmental issues. This is just a little schematic that looks at the difference now between developmental surveillance on the left-hand side and developmental screening on the right-hand side. So to summarize, everyone can have a hand in surveillance, parents and teachers and childcare providers. It's ongoing. And again, Amy's going to talk a little bit more about this in a minute, how we actually can use red flags and developmental milestones. While on the other side, developmental screening is definitely more formal. It is recommended by the AAP. A validated screening tool needs to be used. And again, Ages and Stages is a sample of that. Another one is the PEDS. We've used both in our practice, and we definitely like Ages and Stages better. Oh, maybe I shouldn't have said that. Anyway, next slide. If something does show up on the screening and the child does have a need for a more in-depth evaluation, then that is specifically for a specific disorder oftentimes. So when you're looking at developmental disorders then, these are often groups of conditions, and there's usually impairment, some functional impairment. And I know everyone knows this, but obviously it could be in the physical realm, social, emotional, or behavioral realm, the cognitive or learning realm, or speech and language. And in some instances, thinking about children who do have autistic spectrum disorder, there's crossover oftentimes between these domains. So thinking developmentally then, next slide, it acknowledges the significant influence of the social milieu and past experience on development and on current behaviors. Understanding the cumulative process of development and the long-term consequences of these early disruptions is very, very important, and is what will help us help children have that optimal development that we are after. We're going to talk in some detail then in relation to our case and our discussion after that. What are some of the things then that could come up with a baby who has suffered from NAS, and specifically in terms of his or her development and what we might be able to do about that. And I think keeping in mind too that optimal development requires the presence of safe, of stable, of nurturing relationships, and how we can foster those will definitely have an impact on development. So I'm going to turn this over now to Amy.
Sorry for all the slide flipping. My computer was a little funky for a little bit. I apologize. So I'm going to cover a group of milestones, just talking about social emotional development, to kind of get us thinking about how important these milestones are for overall development for our children. So these little snippets come from the CDC, focused on the different areas of development for each age milestone. So in thinking about that, social emotional development is foundational to cognition, language, and adaptive life skills. So if one of these aren't developing at the pace that they should, there's going to be other deficits that accompany the deficits with social emotional development. An infant's brain development is influenced by environmental factors, which we all know and understand pretty well. And most importantly, these interactions between the child and caregiver are extremely influential on the things that we see on this screen. So the value of social emotional development is that it forms and sustains our positive relationships that we develop as we grow. And it also teaches us how to experience, manage, and express emotions. So again, thinking about how this realm of development is going to impact all other function that we have to do to be successful and functional in our daily lives. Early attachment has a great influence on later behavior and development. So that should make sense already with everything I've already explained, right? It's very foundational. So when child and mom or child and dad are forming those attachments, how that's going to influence everything else that that baby's going to do later in life. In our role as practitioners, we can educate parents on positive parenting techniques to influence all this skill development. We can also role model any of these appropriate child-adult interactions during our sessions or during our interactions with the family to model and influence carryover in the home. And then also provide education to help the caregivers recognize differences in temperament. So if an infant or a child is not responding appropriately in this social emotional realm, what recommendations could we give to that parent to kind of push along or influence it on the right spectrum that we desire? So protective factors, and I feel like this brings in all the other sessions that you've had so far. So strong connections with loving caregivers. Again, as practitioners, we definitely can rope this in and train people how to do this if they're having a little bit of a hard time with it, or just provide that support and encouragement to have that. Creating safe, stable, and nurturing environments. There's lots of great programs that we've talked about so far that do this through the community, but also thinking of what resources we can give the family and the caregivers and whoever else is involved on providing that nurturing environment and making sure that the child's getting that appropriate exposure to help their brain grow and develop and thrive to be successful and overcome the deficits that they've experienced. Another one, opportunities to interact with other children. So if it's a single child home, you know, there might not be other family around, there might not be neighbors around. Maybe having those conversations about, you know, enrolling in other early programs with other children, social groups, community groups, anything like that that's available. Once they're preschool age, they can do the certain government programs that are available to increase that opportunity with children, because having those interactions, again, supports that environmental context and offers those protective factors. And then opportunities to build independence. You know, you might have a parent who is recovering and might be nervous and afraid to let their baby experience things. And when they're exposed to the environment and they're experiencing those things and making mistakes or getting messy with their food, that's the OT coming out in me. They're going to start to build that independence and get that good sensory exposure and help their brain really become what it can be. So fostering that independence and breaking down those barriers. In your slides, I'm not going to click on any of these links, but we offered you guys some different links for different resources that are available. There's some particular to West Virginia, others are nationwide. Some of them have already been mentioned, like Dr. Romano mentioned the Ages and Stages is linked here, and I think Sue put it in the chat as well. So feel free to check these resources out if you've never heard of them. There's all really great things that you can offer to your families or offer to other professionals on your team who may not be available for these sessions to kind of give good collaborative, informal care to the families.
One of the things that I've really enjoyed in working on early childhood issues is working with the National AAP, American Academy of Pediatrics. And we are very proud that over the years, we have developed a cadre of pediatricians across the country who are very interested in early childhood and especially around safety and the health of children in out-of-home care. This group led to the development of a Council on Early Childhood, which is very active nationally. A few years ago, they received a very large grant and now house the National Center on Early Childhood Health and Wellness. And you can go to this site for information at any time. There is a series of videos here, and one of the ones that I helped with is actually about screening and child development. So we're going to go ahead and show that now.
Hello, I'm Dr. Judy Romano. I'll be your host for this episode of Keeping Them Safe. This episode's topic will be child development and your role in supporting healthy development. Regulations or requirements may vary greatly by state or locality, so it is important to follow your local or state regulations. Early care and education settings and staff provide the perfect opportunity for observing and promoting early childhood development. Today, we're going to look at a plan of early identification that will help you, as a care provider or teacher, to ensure healthy development for the children in your care. You can monitor children's development and share observations with parents and guardians and encourage them to share these observations with their primary care providers. The trusted relationship you have with families can help when you communicate concerns and make referrals. You will also be able to assist the child and family in obtaining intervention and follow-up treatment as needed. Increasing numbers of children are spending longer hours in early care and education settings. Often, these longer hours lead to more challenging behaviors, which could even lead to suspension and expulsion of young children. Caring for Our Children is a collection of best practice standards for early care and education programs. This resource recommends that programs should not expel, suspend, or limit services based on a child's challenging behaviors. Information on exceptions to this recommendation can be found in Caring for Our Children. There is an increasing need to build your capacity so that you can serve the overall well-being of the children in your care, including their social and emotional and behavioral health. The social and emotional well-being of young children is an important part of school readiness. This includes children being able to regulate their emotions and behaviors, having proactive social skills like taking turns and waiting, and the skills to verbally express emotions such as frustration, anger, anxiety, and sadness that can lead to challenging behaviors. Let's dive a little deeper into developing a plan that supports a child's healthy development, including social and emotional health. First, we'll address screenings, monitoring, and referrals. Screening is more effective when you have a clear plan in place in your program that tracks and monitors developmental screenings and describes procedures for making and following up on referrals. All the teaching staff should learn how to participate in these important activities. Next, we'll talk about intervention, treatment, and services. If needed, your program should assist the family in obtaining an evaluation by early intervention or special education services. For a young child, age birth to 3, they will be referred to the early intervention system known as Part C. For older children, aged 3 to 5, they will be referred to the special education system known as Part B. Other appropriate community-based services can be used, such as parenting support, a home visiting program, and mental health consultation to support you and families in this process. Programs should also encourage families to communicate with the child's primary care provider so that they can assess the child for any related concerns and help facilitate appropriate referrals. Now let's look more closely at challenging behaviors and 3 ways that your program can respond. First, you could be aware that the physical health of the child may be the underlying issue that is affecting behavior. You may need to adjust your teaching style or activities in order to meet this child's developmental needs. Second, it is important to work closely with parents, guardians, and families. Collaborate around your concerns and what can be done about the child's behavior, including what has worked at home and in the classroom. Third, work with an early childhood mental health consultant to develop a plan to address the concerning behavior and to help the child develop pro-social skills that are appropriate for their development. If you want to find materials on this topic, be sure to check out the resources for staff and families on the video page. Our time's almost over, and I'd like to pose a couple of reflective questions for you to consider. The first is, what procedures and policies do you have in place to help track and monitor children's development? And the second is, what procedures and policies do you have in place to address challenging behaviors and prevention of suspension and expulsion? Thank you for spending this time with me. Please join us on another episode of Keeping Them Safe.
Okay, I'm going to flip back to our presentation. 1 second, lost my spot. Sorry. Okay, so we are ready for our case and we will go into breakout rooms in a little bit. So our case for today to focus on development and screening. Juliet is a 6-month-old female with a history of intrauterine drug exposure. Her 30-year-old mother has a 15-year history of polysubstance use and has received services in her local community through a drug-free mom and baby program with this pregnancy. Her care has included an obstetrician provider, a MAT provider, mental health and counseling, as well as a dedicated transition care coordinator who is a nurse who meets with her regularly. The nurse has developed a plan of care that has been modified according to her needs as she has progressed both in recovery and her pregnancy. At delivery, Juliet's cord screen was positive for her prescribed medication, which is no illicit drugs, and she was monitored for 5 days. She did meet the criteria for NAS, showing increased tone and autonomic dysregulation. There were also social concerns as mother does not have custody of her other children. So in thinking about that case, we have created 4 questions, which 2 of them have 3 have some subsets to them. The first question, which will be Brittany's group, you guys will think about to what services would you refer to mom and for baby Juliet? The second question is going to be for groups that are with Leslie and Abby. This is what are the threats to Juliet's development, and then how will you monitor Juliet's development? The third question is going to be with Susan's group. How can the different professionals and agencies know what the other one is doing? And then kind of thinking a little bit more about that, discuss how your professions would support this case and how it complements others. And then Ashley and Cassie are going to address question 4, which is what can be done if Juliet is not meeting her milestones, and then elaborating a little bit more, what red flags would we be concerned with for mom and for baby Juliet. So everybody will go into their breakout rooms. You guys will have your allotted time to discuss, and then we'll come back and share. And then we also have some recommendations and ideas for each of the questions that we'll go into a little bit more detail about to match those learning objectives that Dr. Romano talked about at the beginning. You're on mute, Melina.
Thank you. I'm going to open up the breakout rooms. I have them set up for 15 minutes. So facilitators, keep an eye for, there should be a 60-second countdown for your last minute before it shuts down. So get your facilitators and reporters ready and get all your last thoughts out before you get stuck. Here they go.
And we're going to turn it back over to Amy, and her and Judy are going to work on seeing what your answers were and giving you the responses that they had talked about previously. Thank you, Amy.
Okay. So let's start with question 1. So Brittany's group, or whoever wants to speak out, would you like to share your thoughts on to what services would you refer to mom and for baby Juliet?
Yeah, so we had a really good discussion and we came up with a list of many different resources. I'm going to list them off, but then we also as a group went through and kind of prioritized what were the top resources we felt needed to be, referred to the mom, like they were, top priority. So our list included referral to birth to 3, home visitation services such as parents as teachers and right from the start, WIC and other nutritional services, a peer recovery coach for mom, recovery services and support such as AA, West Virginia Works, which I learned is similar to TANF, Jobs and Hope, West Virginia Jobs and Hope, monitoring well child visits and immunizations for the baby Juliet, family therapy, housing and transportation services, child services and referrals to help pay for those services, legal aid, and early Head Start. As a group, when we looked at our list, we picked out the top 4, which we thought were top priority, and that was a referral to birth to 3. We did have a nice discussion there that I think is important to note, that infants who are diagnosed with NAS are not automatically enrolled in birth to 3. So I think that's something really important that in the future, all of us as professionals could advocate for and kind of speak on, because that's not an automatic qualifier, even though they are at higher risk for many different delays. The next priority was home visitation services, such as parents as teachers and right from the start, because that kind of will open up the door to many different resources through their home visitation specialist. And then we have monitoring well child visits and immunizations, which is really important. We discussed looking at those different evaluations and screenings for different delays, and making sure that you get to those and they stay on track will be helpful in early identification of those issues. And then also we have child care services and referrals to pay for the services, as the mom is in recovery and she has a high chance of relapse as a possibility of having a child. So it'd be nice for her to be able to have someone to care for her child if she needs a break or if she needs to attend to certain things to help her be healthy.
That is an excellently thorough list, and I think shows the value of interprofessional collaboration and understanding what each of us bring to the team to come up with those ideas and to make sure that you're giving that really great care to the mom and the child and the family and everything else. So that was really great. Thank you, Brittany, for sharing. So here's a little bit of what Judy and I came up with. So referrals specifically for mom, a MAT, mental health provider, postpartum care, contraception considerations, employment or education. Some ideas for referrals, particularly for baby Juliet, are the WIC program, pediatrician, West Virginia birth to 3, and then quality childcare. And in a lot of these, Brittany has already covered, but just kind of honing in on those as well. And then referrals to the dyad, so both mom and baby, how we could help them. So home visiting services, CPS, Medicaid for their needs, parenting support, and then impact. Judy, did you want to elaborate on anything with your experience?
I want to congratulate Brittany and her group. That was a wonderful list. I think you really did a great job on that. The only thing I'd like to say, and we're going to talk about this a little bit more as we get through the questions, is who in the world is going to manage all of that, right? And that's why I think a referral to Impact would be fabulous, because the patient navigator for Impact would be just the person to kind of keep on top of all that. But congratulations to Brittany's group. Great job.
That was very
I want
thorough.
to mention something else. Children, and I didn't hear it, but children with special health care needs has now been charged also to have the NAS population. So that's another referral. And they can provide care coordination.
Thank you, Maggie. Okay.
Can I ask a question? Is Impact a program someplace else in the state?
Judy, do you want to go ahead?
Sure. There are currently 3 demonstration sites, and the counties that are involved, you can go on the Impact website and see. But basically, one of them is our program at Wheeling Hospital, and that is Ohio, Marshall, and Wetzel counties. CASA, also up in the Northern Panhandle, has those counties in addition to Tyler County. And then the other one, Ashley, if you want to talk about that a little bit, you can, but their counties are Harrison, Monongalia,
Harrison, Marion,
and
Mon, Taylor. I messed them up again.
Preston.
Preston. Thanks, Sue.
Okay. So that's not in my area. That's why I wasn't familiar with that. Okay, thank you.
Okay, question number 2, which is Leslie and Abby's groups. So we'll take Leslie first, and she is in my order on my slide. So Leslie, if you or one of your proxies would share, what are the threats to Juliet's development and how will you monitor Juliet's development?
Thank you very much. I'm going to turn it over to Amanda, who's our recorder, and share the screen.
Okay, so some of the threats include the mom doesn't have custody of her other children, so monitor caregiving rights over time. This could create a call to CPS, and possible removal from the mother is another potential threat, as that would impact Juliet's development as well. The mother's continued drug use is a threat. What about her additional supports? Is there a father involved? Is he using substances? Is he supportive? Is he in recovery? Are there other family members available who also provide mom and baby support? Some of the other threats to look at is, does the mother have financial stability to provide for her basic needs? What resources are available to her? Has she sought those out? For example, parenting classes. What are the mother's concerns for now and her future as well? And mom's lack of trust with services. So mom may be uncomfortable with West Virginia Birth to 3 coming to the home if she's had previous CPS experience. She might be a little distrustful of community-based services, thinking that they might just call CPS for any reason, even if she's trying hard to stay on her path to recovery. So in monitoring Juliet's development, talked about collecting mother and baby to other, connecting mother and baby to other services who have monitoring embedded within the policies and procedures, and provide education for the mother, provide resources so that the mother has the capacity to help monitor the baby's development over time. So I was talking a little bit about when I had my children several years ago, and I was given a whole booklet, a binder full of information from the hospital So making sure that she has those resources, that she can at least reference those. I don't know if a lot of hospitals and birthing centers still do that, but it was pretty cool back in the day. Incorporate other services such as parenting education and capture social interactions and other contextual notes while visiting. Use the information to show mother what she could do to enhance Juliet's development in certain areas, and monitoring well-child visits and making sure that mom understands the importance of attending those well-child visits, not just for her baby's medical health, but also for the developmental needs. So the group need identified need for classes for moms and parents who are in recovery, but also trying to raise a small child. An opportunity to go to one place for treatment and receive training that helps strengthen parenting and skills. So we were kind of, there was a question that was brought up, and it was a really good question. Is there a place that mom could go where she's going to get all of this stuff? So if mom has a MAT in the scenario, an MAT provider, mom has a mental health provider, she has, her OBGYN, there's the pediatrician. But is there one place that she can go where she can go to NA or AA? Is there a place that she can go to attend one of those group meetings, take her baby with her? But they also have extra things like parenting skills or adult life skills, helping her to connect to some of those things. So she's not relying on somebody watching over her for every little step. So some of the recovery classes are open for individuals to bring young children, but that is limited, and or the training is particularly focused on the recovery and less so on the parenting piece. So that was a need that was also identified.
Thank you, Amanda and Leslie. That was really great. Before I continue, I would like to invite Abby's group to share.
I think Leslie and Leslie's group did awesome and touched on everything that we said. So I don't have anything additional to add unless somebody else in my group wants to come forward and say anything else.
Anybody from Abby's like to add to it? Okay. So here's our thoughts on question 2. Obviously keeping it simple as per what Amanda described, really great. So what are the threats to Juliet's development? Drug exposure, poverty, adverse childhood experiences, possible maternal depression, the environment, talked a lot about today, social exposure and medical history. And then how will you monitor Juliet's development? So some recommendations, also not as comprehensive as what the group had shared, but surveillance and screening with home visits, which Dr. Romano went through quite nicely, a pediatrician, childcare, and then early intervention services, which are a lot of different specialists involved in that. So Dr. Romano, would you like to share anything? I keep referring to Dr. Romano because this is a real case of a person that she actually works with. So she has some extra insight into all these really goody information for us. So go ahead, Dr. Romano.
This all looks really great. I should probably give a little bit more information that Juliet has missed some pediatric visits, but we're on it as far as getting her immunization. And she is living, Mom and Juliet are living with some other family members, not the father of the baby. CPS has been involved, but it's been nothing but a positive experience. And Mom is doing really well, not showing signs of depression, and parenting so nicely with little Juliet. And I would like to say the recommendation of having parenting and childcare and treatment for mom all in one place, that would just be a dream come true. Places that do that have, very high success rates. So when we're finished with Impact, we can start doing that. Just kidding.
Hashtag goals. All right, question number 3. This goes for Susan's group. How can the different professionals and agencies know what the others are doing? And then to elaborate a little bit more, discuss how your profession would support this case and how it complements others. So questions 1 and 2 have given you lots of good ideas. Who's going to manage all this? So Susan, would you mind sharing?
Sure. Let me look at my notes here. So in my group, we had people from the medical profession, therapists, early intervention, home visiting. So we had a good mix of people. We talked about the fact that this really is a very common problem, that communication between agencies is something, that's a problem that we're very familiar with. We mentioned that it seems to become worse once APS and CPS gets involved due to the confidentiality. And communication with CPS sometimes stops the communication with the providers. They don't know what's going on within the case. So we thought that a release of information definitely needed to be in place, that multidisciplinary teams needed to occur, and strongly encouraged that if you got an invitation to come, you should go. And ask questions, how do I get involved with that multidisciplinary team? We talked about asking clients to share their information, so kind of putting some of that back onto the patient, the client, and asking them to share information between the agencies that the parents are going to have to be willing to share, especially with the voluntary programs like Birth to 3 and home visiting. That more communication could help avoid duplication, and also fill in gaps where services are needed. And then we talked a little bit about how some of the providers use the same assessment tools, so that if we can share the assessment, then we can reduce the trauma by not duplicating doing the assessment. Sometimes they're intrusive and they ask them to tell their story over and over again, and that can be traumatic for the parents. But it also frees up the provider's time. So if a home visitor can use assessment tools that someone else is doing, then that gives them, sessions where they can do other work with the family. Someone from the medical profession talked about how mom and baby have different medical records and different medical providers. So we need to be able to have their providers corresponding. So again, those releases of information to free that up. And we talked about, and I think Amanda kind of led into this conversation, but better engagement with the parents so that they feel like we're there to help them, and they agree to services and they agree to the sharing of the information. We think a lot of our parents are afraid of the judgment, they're afraid of intervention, they're afraid the CPS is going to get involved. And so we want to make sure that we're using language that's parent friendly, and just, helping them understand that we're there to help them and try to get them better engaged. So I hope it did my group justice, because I think they were really fantastic at discussing this.
Yeah, thank you. That was really great. So here's some of our thoughts to add to Susan's group's wonderful input. Set up a means of communication with the team. So she covered that, and obviously this is easier said than done. I think my big challenge to everybody on this call is to not fall into the rut of saying we don't have a communication system in place. That's one of the big challenges of interprofessional collaboration and teamworks, and knowing other people's roles and responsibilities, and just having that opportunity to talk to others. So not just saying we don't have a way, but kind of figuring out a way to do it. You're going to get a lot of great contacts through this group. If it's in a professional email or phone conversations or something like that, just because we might not have a formal system. I think as healthcare providers in today's world, we really need to challenge ourselves to collaborate with others and not just fall into the old rut that we get stuck in, that nothing's really set up and our systems don't match, and we can't do that. So that definitely is a challenge that Susan really did talk really nicely about, but I think all of us have the ability to go above that. And I think we can do it with the drive of having the patient and the family in our end sight. So also including the role of the patient navigator, make use of the electronic medical records. There's a lot of opportunities on those that we probably don't use. So maybe having some more insight into what the tools are on those EMRs. And then develop methods for warm handoffs. So I put the definition of that on this slide. So I'll just read it. A warm handoff is a transfer of care between two members of a healthcare team. We've heard of stuff like that before, but the important part of the warm handoff is where the handoff occurs in front of the patient and family. So keeping them as part of the team, right? All of us on this call are professionals who are part of that healthcare team, but also including the patient and family in that team. And that's part of that warm handoff where they're hearing, and maybe they're going to be our grand communicators to the other professionals in our group who can help have better care. So Dr. Romano, anything to add to question 3?
Between you and Susan, I think you nailed it.
Okay, good to know. Thanks. All right, question 4. So this is a 2-parter again. And since Ashley's listed first, I'll ask her to report. So what can be done if Juliet is not meeting her milestones? And then what red flags would be concerned with for mom and for baby? So Ashley, would you mind sharing?
Sure. So for what can be done if she's not meeting milestones, my group said refer to Birth to 3 and West Virginia Impact. And then they wanted to know it would be important to know if the child is on the spectrum. And then also utilizing the CED as a resource. And then they also talked about the home visitation program, especially early Head Start, parents and teachers, and right from start. And also a thorough physical exam by doctors for the regulation and tone in the legs to make sure that there's nothing physical going on. And the conversation begins with the mom. We want to see where is she in all of this before we go and give her a bunch of referrals, and then provide reassurance and encouragement to mom that not all babies reach milestones at the same time, since she did previously lose some children. And red flags would be, 1, if the nurse is using one of the screen tools to show delays such as not walking or talking, looking at the protective factors as well as the interactions between parent and child, and is the mom aware of what the milestone should be, and also looking at the child behaviors. Is it hard for the child to calm down, stay asleep? Are there sensory and motor issues? And finally, what is the mom's situation? Is she stable? Does she have food, clothing, etc.?
You're on mute, Amy.
Sorry about that. Cassie, you're up. Did you want to share your screen? Because I know you usually do. I can stop sharing.
Sure.
Okay. Go ahead.
Our group found some very similar things, but a couple different things. We did red flags first. Is baby Juliet irritable, tight, can't calm or soothe? Is she difficult to handle? Keeping an eye on her weight, constipation, milestones like rolling over, not tolerating tummy time, having any difficulty with attachment, not smiling or cooing back and forth. Her overall care, cleanliness, diaper rash, is she responding to environmental stimuli? And is there, a high amount of reflux, more than what we would expect? For mom, is she experiencing increased stress, increased frustration, a lack of sleep? Maybe breastfeeding isn't going well. Is she shutting down? Is she seeming like she's at a higher risk for substance abuse or postpartum depression? For actions, they were very similar to Ashley's group, Birth to 3, screeners at the pediatrician, early intervention programs, WIC, children's special healthcare needs. And for mom, recovery support, community or family respite support, reconnect with her sponsor if that was something that she found comfort with previously, mental health support, the 5 S's for calming, and faith-based support if that is something that mom has a high interest in. That's it.
That was great. I was lucky enough to sit in on Cassie's group to follow them along, and such good brainstorming. So between Ashley and Cassie, probably not too much more to add to this first part. Maybe just a little bit of a different thought. So if Juliet's not meeting her milestones, I think it's best to stop and rethink, and then go in a holistic manner, as you guys have seen today beautifully, the value of everybody working together and bringing in their strengths and collaborating. So if there's a hole in the problem solving, that's the best time to pick up the phone or send an email, or connect with someone to get an idea of how they can facilitate what that missing hole is. So kind of a little bit more specific. So thinking about, is it a physical concern? So is Juliet having difficulty with motor, cognition, social, emotional, behavior development? The list could go on and on there. Also thinking about environment. So what's going on in the environment that could be halting the milestone development. So is something going on with mom that we're not aware of? What's going on in the home? Are there other people in the home? Environmental exposure with toys. We talked about that nurturing environment, toys, books, sounds, right? All that good stuff that really helps brain development, and then exposure. So that's the first part of question 4. Dr. Romano, anything to add to this part?
No, I think that looks great.
Okay, and then the second part. So I did a little bit of a different thing on this slide. I didn't put our suggestions for this answer. What I put up here is to show you what a baby of Juliet's age should be doing. So I assumed, and it was a safe assumption, that the groups who addressed this would really cover this thoroughly, so I didn't think it would have been valuable to make a list. But for us to think about what a typically developing child with no concerns would be doing at this age. So really good social emotional development, interacting with everybody around, comparing familiar faces to non-familiar, language and communication development, stringing vowels together, responding to their name, making good sounds with consonants as well. Cognition, looking around, bringing things to mouth, having curiosity, using both the hands together to play, and then movement and physical development, beginning to sit without support, rolling over. When I was in Cassie's group, they talked about rolling, and when having that increased tone or pain or aggravation that a lot of babies get with NAS, do they want to move, right? They got a lot of pain, and sometimes they get hiccups and all those other things that would cause them to not want to do those movements. Standing, supporting weight on legs, so cruising, and then rocking back and forth. So this is what we would expect of a baby of Juliet's age. So we also provided more resources in addition to what we had on that previous slide. These are just things, the warm handoff. This CDC link is really great. It addresses all the domains of development that you can check out at all different ages. So that's a really useful resource if you're looking for a quick glance at milestones that babies and young toddlers should be meeting, with both of those links to the CDC. And I am missing that last slide, so hold on one second. Give me to, Dr. Romano, would you like to chat while I bring up that last slide?
Sure. I just want to thank everyone. All of your suggestions were amazing and very, very helpful. While she looks for that last slide, what we were just going to end with was talking about what are some of the long-term developmental outcomes for children who have been diagnosed with NAS. And unfortunately, the research is all over the place. We really do not have any hard and fast rules about what happens because, as you can imagine, each and every case is so very, very different. it appears that there is at least some difficulties with some cognitive issues, some social emotional issues. Now, we can't say with certainty that this is because the substances, because most of the time the substances that the baby has been exposed to are polypharmacy, not just one. You know, it's very rare that you find a baby that has been exposed only to opioids. I did do a little bit of a summary slide here just to give you some ideas of what people are finding. And it's everywhere from decreased volume of motor cortex to difficulties with cognitive and language development. So what I would caution folks is not to focus on any of these outcomes per se, but to do exactly what we've been talking about this whole session, which is to be aware of how we can assist moms, families, and how we can have at least a two-generation approach to all of these problems to really maximize the developmental outcome of each one of these babies. And I would certainly welcome in any other questions or any other comments at this point.
If I could just say one thing, I really do wish NAS would be an automatic qualification for West Virginia birth to 3. I don't get a say in that, unfortunately, but what we really do is work very hard to turn over every stone to help them qualify. Families usually find that once they're in the program, they don't want to ever leave, and it's heartbreaking when at 3 they're turned over, but we really do work to support the entire family. It's very much family and parent led. So I wanted to throw that out there. So if you ever hear about NAS and the possibility of it becoming an automatic qualification, please support it.
Does anyone else have any other questions or comments?